Quality in senior care. What does it actually mean? Providing both quality of care and quality of life are primary goals in senior care, regardless of the setting. Whether it's a skilled nursing home or an assisted living community, quality is on the minds of everyone, from the leadership to the care staff, residents, and families. The phrases quality of care, quality of life, quality of everything are used so frequently. But what do they mean? Let's deconstruct quality of care. According to experts in the current literature on this topic, quality of care is multidimensional and quite elusive as a phenomenon which is complicated to both define and assess. An author on quality of care, Avitas Donabedian, suggests that there are three elements involved, including structure, process, and outcome. We're talking about quality of care. Three elements: structure, process, outcome. Structure refers to the many conditions that may affect the ability to deliver care to seniors, including staffing levels, staffing mix, and characteristics of the environment. Process, as you may have guessed, refers to work, flow, and processes, routines, and procedures. And then outcome is the end result. The end result of care, whether it's good or bad, adequate or not, what is the outcome? There are also other ways of looking at quality. Two dimensions: care and life. And I talk about these quite often. Another way to approach the meaning of quality is to break it down into two different dimensions and to examine each one. Quality of care. What is that? It refers to clinical outcomes like pressure injuries, the use of restraints, psychotropic drugs, or falls. It focuses on both the quality of care delivered by nursing staff as well as the safety and safety issues of the resident. On the other hand, quality of life encompasses the resident's well-being, opportunities to make meaningful choices, to exercise autonomy and independence, and to engage in activities and things they like to do. Quality of care and quality of life. Now, how do we assess it? How do you examine it and tear it apart and determine if it's good or bad or great or not? As complex as it is to define quality in senior care, it is also difficult to assess. One approach is to examine primary data sources, like self-reports from residents themselves, their relatives, family members, close friends, care staff, and through field observations. But this technique is time-intensive and expensive. The other way to assess quality is through the use of secondary data sources like national data sets of clinical assessments. And the most commonly used data set that everyone in skilled nursing is very familiar with is the MDS, or the minimum data set. So you could go farming or mining for information to determine what quality is and how to assess it, okay? So there is a need for task-oriented leadership when it comes to quality. Let me explain. Most experts agree that effective leadership is a critical component to both quality of care and quality of life. I think you would agree, right? Leadership is a topic of a great deal of research, and it focuses on different styles, traits, behaviors. On my blog, I talk about different types of leadership all the time. But regardless of the style, task-oriented leadership appears to be directly associated with higher quality of anything, quite frankly, in senior care. This type of leadership involves the behaviors of planning work activities such as what to do, how to do it, when to do it, and who will do it. Okay? It also involves clarifying roles and objectives, such as communicating plans, policies, job responsibilities, role expectations, requirements, and goals. Those are very concrete things. Monitoring operations and performance is also a key part of task-oriented leadership. Now, it's funny that I'm talking about quality, and I'm an advocate of person-centered, focusing on the resident, and now I'm throwing in task-oriented leadership. Did you catch that? I hope you did. But they go together. They go together. So, along with monitoring operations and performance, this involves gathering information about the processes, the progress, the performance, and individual contributions within the care community. Now, so you have task-oriented leadership, but relationship-oriented leadership is needed as well. On the other hand, relationship-oriented leadership includes supporting staff and involves consideration, acceptance, and concern for their needs and their feelings, which might also be based on residents. It also focuses on building and developing skills, as well as praising and showing appreciation of performance. So, at the end of the day, which is better? Task-focused or relationship-oriented? Task-oriented, relationship-oriented. There should be a balance of the two, okay? So it's important to find that balance. Whether the leader is transformational, democratic, or practices servanthood leadership, a balance of task and relationship-oriented leadership may be the best formula to enhance and maintain quality of care and quality of life. Good leaders use a pattern of behavior that fits the situation and expresses a high concern for both the tasks and the relationships. It's not one or the other. My final thoughts are quality is the most important outcome concerning care in senior living. While it's often expressed, quality may be complicated to define and to measure. Regardless of how it's approached, it does require a well-prepared and committed staff who is led in both getting things done, tasks, as well as maintaining healthy and positive relationships. There you have it. My take on quality in senior care. What the